Hello everybody. So this is lecture 3 part 2 of the co-occurring disorders course. We just finished off with depressive disorders and now we're going to go on to bipolar disorders. The disorders we'll be talking about here are bipolar 1, bipolar 2, cyclothymic disorder, substance medication induced bipolar disorder, or bipolar disorder due to a medical condition, which we more so will be talking about at the end once we're done with talking about these primary bipolar disorders. So right now we're going to mostly be focusing on these first three here. First off, bipolar 1. This is an important thing. I'm going to talk right now about how to distinguish these before I go into actually talking about how manic and depressive episodes work. So we'll go into that next. But first, let me review this with you. Bipolar 1. The way you distinguish bipolar 1 from any other bipolar disorders is that full mania is present. And any time you experience or you see full mania in a client, then bipolar 1 has to occur. This can include a major depressive disorder or hypomania, but what's most important is that if full mania occurs, that's bipolar 1. Bipolar 2 occurs if there is both a major depressive disorder and hypomania occurring. So basically, if you have major depression and you have major depressive disorder, then that's what you have. As soon as any kind of hypomania occurs, then you would apply the diagnosis of bipolar 2. If somebody ever at any point who has bipolar 2, if they ever experience what we consider a full manic episode, then that diagnosis should be switched from bipolar 2 to bipolar 1. And finally, we have here also cyclothymic disorder. Um, with a cyclothymic disorder, you do not see either a major depressive disorder or hypomania occurring, just depressive or manic symptoms continuously for a 2-year time span. So I'll talk more in detail about what this all means when we're actually looking at these particular disorders. First off, before I do that, a couple of statistics. Lifetime prevalence of individuals with bipolar developing a non-tobacco substance use disorder of any kind is about 40 to 60%, which is a very high rate. SUD development peaks between ages 14 and 20, so that's in young adulthood or adolescence there. And most individuals seek treatment when in the depressed phase. So that's important to keep in mind too, because of what we'll talk about when it comes to mania. Very oftentimes, clients who experience mania find the experience to seem very pleasurable, and you'll understand why when we talk about the symptoms of mania in a little bit more detail. But it's good just to keep in mind that depression never seems to feel good for anybody. And so this is when an individual with bipolar is going to be more likely very motivated to come see you. So you're not often going to see mania in a client who's coming to see you your first time, which can be a bit challenging, right? Because we're often trained to do the assessment right away, our first or second session. Well, it may not be until a month, 2, or even 3 months. Who knows? It can be an even uncertain amount of time before you'll actually see a manic episode. So you may not initially notice people having what we'd consider bipolar until maybe you hear about these symptoms at some point down the road. And people may be diagnosed with depression before you see that. So moving on, manic depression, manic episode. So a full manic episode this would be. If somebody has this, then they would have bipolar 1. At least 1 week, most of the day, nearly every day, of elevated, expansive, or irritable mood and abnormally persistently increased goal-directed activity or energy. So that's kind of a big descriptive paragraph right there, right? When we say elevated or expansive mood, this is what we use the word grandiose very often to describe. So that's going to be one of the first symptoms, actually, inflated self-esteem or grandiosity. So basically, we just see someone who's seems very happy, excited, energetic, just thinking about all things at once, basically. That's what we mean by expansive and elevated. Just, they seem the opposite of depression, basically. Sometimes it may also include irritable mood. So you can see that too, anger and irritability. But more importantly, let's look at the rest of these symptoms. Inflated self-esteem or grandiosity, Decreased need for sleep. So oftentimes you'll see people reporting that they're only sleeping about 3 hours each night while they're in a manic episode. They're going to be much more talkative. There's going to be this kind of noticeable pressure to keep talking, so we're going to see rapid speech occurring, much more than you normally would see in them if they were in a depressive state. There's going to be a flight of ideas or subjective experience of racing thoughts, so we can see how symptoms 3 and 4 are going to very much align with each other. As I mentioned before, speech is really the only way that we can indicate or predict somehow or estimate thought patterns, right? So rapid speech is very likely going to also show us a flight of ideas. Now the difference is that someone can be speaking very rapidly, but in order to have a flight of ideas, we have to see this person changing topic very often, very repeatedly, maybe even in the same sentence. They're going to be shifting from one idea to the next. That's how you're going to distinguish between a flight of ideas and someone who's just very talkative. So these aren't the same symptom either. Distractibility, report or observe, so that could even seem something like ADHD, somebody who's very easily caught off and, talking or distracted by things in their environment. Once again, we can distinguish that from a flight of ideas, because flight of ideas would be all things that they're talking about from memory or reporting as internal experiences. Now, if distractibility would have to be something actually in their environment or a sensation in their body that occurs in real time that distracts them onto a different topic. Increase in goal-directed activity. This can be anything, but you'll see many people in manic episodes suddenly take on a very expressive and passionate interest in a new activity. Strangely enough, one of the most common things I've actually seen among individuals in manic episodes has been um, aquariums, actually, like putting a lot of work into some kind of home project like an aquarium. Seen for very large aquariums. Other things can be things like cars, books, or other sort of career-based goals that they become very interested and motivated with passionately. We'll see excessive involvement in what we consider high risk or high cost activities too. So, for instance, a sports car is going to be a very expensive and costly hobby that someone may suddenly become compelled and highly invested in. Now, we can see that this is where the real pull for somebody with bipolar occurs. I mentioned before that most often you're only going to see someone come looking for treatment when they're in the depressive episode. People tend to be very tempted to try to stay in mania as long as they can because of how productive and creative they feel they are in that state. And for the most part, they will be a bit more productive and creative. The problem is that these behaviors, because they're occurring so intensely, is not sustainable, and a crash is almost always imminent. Strangely enough, the DSM-5 does not require a person to experience a crash in feelings to be diagnosed with bipolar 1. All they really need to have is one full manic episode like this. Now, what's really important to distinguish manic episode from hypomania, which is the less severe form, is the disturbance is severe enough to cause marked impairment in social or occupational functioning or cause them to have to be hospitalized. So we're seeing here that these symptoms are so severe, so powerful, that this person is beginning to, over time, lose functionality. They are becoming greater and greater fatigue. This is taxing their mind and body and finances to the point where they cannot function. Maybe they're getting fired from their job because they're so distractible and so difficult to work with when they're in this type of mood. So another important thing to keep in mind, that's the primary way we distinguish this from hypomania. So let's look at hypomania. At least 4 consecutive days. So 4 rather than at least 1 week, a fairly minor difference, right? 4 versus a full week seems like not much, but when you consider just the intensity of this condition, it makes more sense. Consecutive days of elevated, expansive, or irritable mood and increased activity or energy. At least 3 manic symptoms present. 4 symptoms if only irritable. So they make an interesting distinction here, is that if they don't have expansionism or elevated mood, if it's just irritability, then they say we need a few more of the actual symptoms to consider this some sort of episode. This episode has to be an unequivocal change in function, which means that you have to really be able to notice that this is different than the person normally behaves. This change has to be observed by others, observable by others. Now here's really the big difference. Well, there's a few differences, right? The duration. The duration is shorter, 7 days, but this is only 4 days for hypomanic. When you look up at the manic episode, 3 of the 7 symptoms, at least 3 manic symptoms have to be present here too, so that's the same. Episodes unequivocal change, but here's really the main kicker here down below. Not severe enough. So the symptoms, this condition has to actually be not severe enough to cause marked impairment in social occupational functioning or hospitalization. Now, interestingly enough too here, we see that this is one of the few disorders, hypomania and mania, where they don't necessarily say it has to do anything, have to cause any form of distress, right? Because what we're talking about is a disorder that causes elevated expansive mood. So very positive feelings, right? This person may not actually be experiencing any form of subjective distress. And it's not required diagnostically for this person to be experiencing distress. Very few disorders don't include distress, and these are probably one of the only few that don't. So keep that in mind. Really, the only difference between mania is shorter duration and does not need to cause impairment in social or occupational functioning. Other than that, they draw from the same symptoms. All right, so we're moving on to another concept here, how we make differential diagnoses. So I think I'm going to stop this video here and then pick up with part 3 to do the next section.